What about using genetic information into trying to predict who's going to get colon cancer and screen more effectively? We used to think that colon cancer took 5 years to go from a polyp to a tumor. But what we now know, in fact, is that it happened 17 years earlier. Not 7 years, but 17 years. If you look at this is data from Dr. Bogelstein's lab in Baltimore. If you look at the 6-year to 17-year mark, in fact, in tiny little adenomas that are not visible to the eye, you already begin to get genetic changes that are sloughed into the epithelium of the bowel. From that point, it goes to a large tumor and finally to metastasis. We are moving the time for detection way past the point that you'll ever see it on a colonoscopy. You can actually take those early genetic abnormalities and screen stool and screen blood and do something called fluorescent in situ hybridization, or FISH, or flow cytometry, and you can pull out a small population of mutant alleles. That is the kind of analysis that we do here in this hospital every day, but we don't, and you'll be able to determine who is going to develop colon cancer and the risk of developing colon cancer. And this is what early studies have shown, that for patients who have Dukes A or Dukes B colon cancer, which is early stage, in stool, we have a 90% detection rate. 90% detection rate. That's huge. Even for patients that have tiny adenomas, we have a 70% detection rate as a blood test or stool test. So we are moving to the point now where we'll be able to do mass screening on the basis of a blood test or a stool swab and be able to predict when we need to go on to a colonoscopy. Our colonoscopy rates in the United States are about 45 to 50%, which means that for everybody above the age of 50, only about half of all Americans are appropriately screened for colorectal cancer.